All right, let's jump straight into the test day mindset and build out our core diagnostic algorithm. To completely conquer pediatric musculoskeletal presentations on Step 2 CK, you've got to move beyond just memorizing random facts and really master the underlying clinical decision logic. Let's do this.
So, the absolute crucial point in any pediatric ortho question is navigating your primary decision nodes. Before you even glance at the answer choices, you need to filter the clinical vignette through these specific parameters: patient age, presence of trauma, their ability to bear weight, any systemic symptoms like a fever, hip range of motion, and finally, any abnormal neurologic findings or neck posturing. For instance, if you see a fever and an inability to bear weight, boom, you're thinking septic arthritis. Abnormal neurologic findings? Think severe scoliosis. A persistent neck tilt? That points straight to torticollis. Let's apply this framework, starting with lower extremity alignment.
Let's map out physiologic alignment so you know exactly when reassurance is literally the only treatment you need. You see, alignment shifts naturally as a child grows. At 6 months, genu-varum or bow legs is totally physiologic. By 2 years, the legs should be perfectly straight. Then, they naturally swing the other way into genu-valgum or knock knees around ages 4 to 8. Finally, by age 7 and beyond, they straighten out again. Knowing this exact timeline is absolutely crucial so you don't over-investigate completely normal symmetric bowing in a kid with normal stature. Now, what's really interesting here is how we contrast that normal, symmetric bowing with a pathologic lateral thrust. When a child walks and you see the knee joint visibly protruding laterally with bearing, that strongly points away from simple physiology. If the bowing is persistent past age 3, or you see this lateral thrust, you've got to suspect Blount's disease, which might actually require surgical intervention.
Okay, moving down the trauma branch. If a vignette describes an ambulatory child under age 3 who presents with a limp or maybe refuses to walk after a totally low-impact twisting fall, look really closely at the X-ray. You'll see the spiral fracture of the distal tibia. That's your classic toddler's fracture. Treatment here is just simple immobilization and reassurance. And here's a super high-yield test day tip. Early walkers get bruises on their knees and shins all the time from typical falls. Do not mistakenly overcall normal bruising or a simple toddler's fracture as osteogenesis imperfecta.
Moving up to the hip, developmental dysplasia of the hip, or DDH, is a massive board favorite. You need to rapidly identify the risk factors here: breech positioning, a positive family history, and excessively tight swaddling. Clinical red flags include a positive ortolani maneuver, which is that audible or palpable clunk when you abduct the hip and lift anteriorly, or a dislocated hip with limited abduction. And this visual brilliantly illustrates the supportive physical findings you absolutely must recognize for DDH. First, you have apparent femoral shortening on the Gay-Lozzi test, simply because the dislocated femoral head is sitting posterior to the acetabulum. You might also spot asymmetric hip folds, specifically an extra fold on the affected side, alongside a potential limb length discrepancy. And remember, if DDH is missed in infancy, it's going to cause early osteoarthritis in childhood, presenting as chronic groin pain. We definitely want to avoid that. Step 2 CK loves age cutoffs, so please commit this diagnostic logic to memory right now. If you have supportive findings or risk factors for DDH, your imaging modality depends entirely on the infant's age. Because the femoral head isn't fully ossified early on, use an ultrasound if the infant is under 4 months old. But the exact second they hit that 4-month mark and beyond, you have to switch your diagnostic tool to a hip X-ray. If intervention is actually needed based on those red flags or imaging findings, you're going to refer to orthopedics. The treatment is this rigid Pavlik harness. It's a splint that specifically holds the hip in constant flexion and abduction, while actively preventing extension and adduction. This ensures the femoral head stays firmly seated right in the acetabulum, allowing for proper joint development. All right, let's switch gears to the limping child and see how leg calvi-perthus builds are differential. This is idiopathic avascular necrosis, or osteonecrosis, of the femoral head. Your classic patient here is a boy between the ages of 3 and 12. They're going to present with an insidious, really gradual onset of hip pain and a limp. On exam, you'll find restricted hip abduction and internal rotation. They can usually bear weight, but they might have a positive Trendelenburg sign. Keep in mind, early X-rays in leg calvi-perthus might be completely 100% normal, but in later stages, the X-ray reveals flattening, fragmentation, and sclerosis of the femoral head. If that X-ray is negative but your clinical suspicion is high, an MRI can show the necrosis early on. Management centers heavily on non-weight bearing, splinting, and potentially surgery.
Okay, quick pause for some active recall to test your algorithmic thinking. An obese 13-year-old boy presents with isolated, dull right knee pain and an altered gait. You examine the knee and it is completely normal. So what must you immediately suspect on test day?
The answer is slipped capital femoral epiphysis, or SCFE. The massive key clue here is that hip pathology often presents purely as referred knee pain in adolescence. So, if the knee exam is totally benign, check the hip. The exam will also reveal limited internal rotation. Now, SCFE typically occurs in obese adolescents, but if you see SCFE in a child under age 10, or if it presents bilaterally, you've got to suspect an underlying endocrinopathy. On the X-ray, you'll see this classic posteriorly displaced femoral head. It literally looks like a scoop of ice cream slipping right off a cone. Once you diagnose this, it mandates immediate non-weight bearing and surgical pinning. The major complications of missing an SCFE are avascular necrosis of the femoral head and severe osteoarthritis down the line.
Shifting our focus down to the foot, you must be able to rapidly differentiate between two very common neonatal presentations. Metatarsus adductus is characterized by flexible positioning. You'll see medial deviation of the forefoot but a neutral hindfoot. Because it's entirely flexible, the treatment is just simple reassurance. Contrast this with congenital clubfoot. Clubfoot features rigid positioning, medial and upper deviation of the forefoot and hindfoot, and hyperplantar flexion. This requires prompt serial manipulation and casting, and even surgery if it's refractory.
Notice that medial deviation of the forefoot seen here in metatarsus adductus. This condition is very often bilateral, and we see it most frequently in firstborn infants. The primary cause? It's simply crowded positioning within a smaller primogravid uterus. Because the foot is completely flexible, it self-resolves. So again, you just reassure the parents.
Finally, let's distinguish normal growing pains from pathologic leg pain. Growing pains happen in kids aged 3 to 12. Crucially, the pain is bilateral and non-articular, meaning it's in the muscles, typically at night after daytime activity. It's perfectly associated with a normal physical exam and zero activity limitations. In stark contrast, any pain that is unilateral, articular, persistent, progressive, limits the child's daytime activity, or is associated with systemic symptoms like a fever, demands immediate further pathologic evaluation. For example, if you've got pain with a fever, an inability to bear weight, and elevated inflammatory markers, apply the Kocher criteria. You need to differentiate transient synovitis, which usually follows a viral URI, the child looks well and can bear weight, from a true surgical emergency like septic arthritis. Septic arthritis features a synovial white blood cell count over 50,000 and needs urgent drainage and antibiotics.
Let's lock this all in with our rapid-fire summary of our test day logic. 1. Know your physiological alignment timelines. Varum early, valgum later. 2. Strictly obey that 4-month ultrasound versus X-ray imaging cutoff for DDH. 3. Immediately identify referred knee pain in an obese adolescent as SCFE and prioritize immediate non-weight bearing and surgical pinning. 4. Evaluate an infant with a head tilt and SCM mass as having congenital muscular torticollis, making sure the chin points away from the affected muscle. 5. Perfectly apply the Kocher criteria to separate septic arthritis from transient synovitis. 6. Use an X-ray to find a Cobb angle greater than 10 degrees to diagnose adolescent idiopathic scoliosis. You'll brace at 30 degrees and consider surgery at 40 degrees. And finally, 7. Remember that supervised strength training is completely safe for mature children around age 8, provided they avoid excessive loads. You now have the exact structured framework to attack these pediatric musculoskeletal vignettes with total confidence.